All right, I think it's time. We'll get started. Thank you everyone for joining. I'm very excited about Grand Rounds today. But before we get started and introduce our speaker, I'm going to just share the screen and get you situated with the CME and the MOC credits and how you could get them. Again, this lecture will be recorded and stored on the websites. Please feel free to go there and please spread the message. This is going to be a great time for us to be able to hear some of the legend in cardiology. For the CME credits, the text is on the number 20401. Please send it out to 888-816-4893 as an SMS message to get a CME credit. And if you are a physician, you will be able to complete the step 1 and get a maintenance of certificate points directly to your ABIM ID if you're maintaining a cloud CME profile. And there is a link here that will be displayed back and will be available for 12 hours. You can go in with the room code future 2024 and answer the questions. And if you get them right, you get the credits right into your ABIM ID. All right, so one more time, CME credit 20401, and then you have the room code future 2024 for your MOC credit. All right, so with that, I'm really excited and thrilled to be introducing one of the legends in cardiology, Dr. Renu Virmani. Dr. Virmani, welcome. And it's been a great pleasure having seen you and hearing your talks in the recent past when we had an opportunity when I was at West Virginia, and it's so great to see you back. Dr. Virmani, I always do this great, it's a fun part is to be able to meet and read through their CV. So I printed out Dr. Virmani's CV. If you would see, it's about 200 and plus pages long. So I'm not going to be able to go through them, all of it, but the most important parts I will try to cover. Dr. Virmani was in India when she completed her medical education from Maulana Azad Medical College in Delhi University, and subsequently went to Lady Hardinge Medical College, and her research was on cell-mediated immunity in breast neoplasms. She subsequently had residency in OBGYN and then switched over to pathology and went on and became a visiting scientist at NHLBI in 1975. Subsequently, she had a residency in pathology and was a staff fellow at NHLBI and became a staff pathologist and chief of the Division of Cardiovascular Research in the Department of Cardiovascular Pathology at Armed Forces Institute of Pathology in Washington, D.C. She subsequently had her role as the director of the autopsy services at Department of Pathology at Vanderbilt. And then she came back to Washington, D.C., where she was in the Department of Pathology at Georgetown University. And she was also in the University of Maryland, Baltimore in Maryland. Currently, she is the president of the CBPath Institute, which is an independent nonprofit organization doing work in cardiovascular diseases. And she has been working for the last about 20 years from the Institute. Her work has been primarily contributing to the characterization of human coronary plaque rupture, vulnerable plaque, and plaque erosion. She has contributed to the work of human coronary stent thrombosis and stent failure, extensively studied in animal models, and contributed to the methods and mechanisms of inflammation followed by neointimal growth. She had discovered the understanding behind atherosclerosis as an important contributing factor to late vascular complication, including very late stent thrombosis, and has been a leading pathologist in numerous clinical trial and studies in cardiovascular devices and imaging modalities. More recently, she has also had interest in understanding the pathological effects of SARS-CoV-2 in heart diseases. She has a very extensive record of grantsmanship. She's currently actually a co-PI in a LEDU grant, and she has had distinguished positions and appointments and honors. Just to recognize a few of the several, she was a Distinguished Achievement Award holder from the Society of Cardiovascular Pathology, ESC Andres Grunzig Lecturer in Interventional Cardiology, Simon Dack Award from JACC Journals, TCT Career Achievement Award from Cardiovascular Research Foundation, Female Luminary Award from the Sky Foundation, to name a few. And when I went through her CV, it's just enormous. 927 lectures, over 900 manuscripts, 26 letters and editorials, 427 abstracts, 168 chapters, 7 edited books. So she's a legend in her field, and it's a great honor to have you, Dr. Vermani. And joining you today for the panel discussion after your presentation will be Dr. Tudor Voginescu, Director of the Cath Lab, and Dr. Ramzan Zakir, Director of the CTO program. So with that note, welcome, and we look forward to your lecture. I think you're muted. You're still muted, Dr. Vermani.
Let me share my screen. Where's the, I can't. No, it's over here. Yeah.
Perfect.
And thank you for welcoming me, and it's a pleasure to be with you and to give this lecture on atherosclerosis, which has been my love for over 40 years. I think I've worked in this field for many, many years now. These are my disclosures. I'd like to start with the incidence coronary artery disease and sudden coronary death. The prevalence of coronary vascular disease in the US adults more than 20 years of age is much higher in males than in females. And you can see overall hypertension plays a very large role. That hypertension is present in every age group, 20 to 39, 42, and so on. You can see this. But if you look at the death contribution of cardiovascular disease, it is very high. And it has been coming down, as you can see, in some of these years. Since the year of 1890, since then, we've been declining. However, in the last 3 to 4 years, or even 5 years, there is a small increase, but significant increase in the incidence of sudden death. And my interest in sudden death, especially with atherosclerosis, is the first-time presentation of these cases. These, what I'm going to show you, are going to be from cases of sudden death that have occurred as a first manifestation of heart disease. How do I go to the next? Oh, no. Okay. The incidence of sudden coronary death definition is sudden death defined as occurring within 1 to 6 hours of the onset of symptoms. This is what we've used, or within 24 hours of the time that the victim was last seen alive in normal state of health. Then if you look at overall incidence in less than 35 years of age, the incidence of coronary heart disease is only 10%. But when you go beyond 35 years of age, it becomes 80%. So it's a real cause of sudden coronary death, and that in majority of the cases, if you go to medical examiners, they will tell you 80% of their deaths are natural deaths and occur from coronary heart disease. So I start with the classification of atherosclerosis. This was first described by Starry in 1995, and they divided into 6 different types of atherosclerosis. First, defining it as intimal thickening, fatty streaks, intermediate lesion, fibroatheroma class 4, atheroma and then fibroatheroma and complicated lesions, which included plaque rupture. Majority of the cases in those days, they thought everything occurred. The thrombosis was basically from plaque rupture. And then I'm going to ignore the right side of it. So when we came out with our classification, they modified their classification, and the editorial was written by Starry. And what they did was they further classified into fibromuscular disease, tissue layers produced, and there is fibrous layer, and then surface defect, hematoma, thrombosis, and calcification predominates in the seventh type. And then the 8th is fibrocalcific plaque predominantly. So this is the classification that we came up with my colleagues. We think there are progressive lesions and there are non-progressive intimal lesions. The intimal thickening is the first lesion that occurs from simply blood flow. Now, intimal xanthoma is same as fatty streaks, what used to be called as fatty streak. That is, the wall is infiltrated by lipid, and mostly from foam cells. These are lesions that can regress. Therefore, I don't call it as an atherosclerotic disease, as a non-progressive, non-atherosclerotic disease. I think progressive atherosclerotic lesions begin as pathologic intimal thickening. That may be with surface macrophages or without. This is with surface macrophages. Fibroatheroma early and late, and then thin cap fibroatheroma, which is a terminology which is also known as the vulnerable plaque, where it resembles, and I'll come back to that, it resembles plaque rupture. Now, what are the causes of thrombosis? There's not only one cause of thrombosis, which in the original classification, AHA, was that plaque rupture was the only cause of thrombosis. And this is when the fibrous cap disrupts and there is luminal thrombus because the blood comes in contact with the lipid. Plaque erosion was described by us, and we say that this can occur in a lesion which is with an underlying pathologic intimal thickening or underlying fibroatheroma. And these lesions have very little calcification, and I'll come back to that. And the third lesion we've described is calcified nodule, where the calcium is broken into multiple pieces and protrudes into the lumen and no longer has a covered fibrous cap, but is in contact with the blood flow, and a thrombus forms on the surface. And then a few lesions like plaque fissure have also been described, where the lumen may or may not contain much of a thrombus, and that this is in communication with the necrotic core, and it is lined by macrophages often. And this is seen in about 10% of cases, according to Michael Davies, who described the original plaque rupture. So what is the incidence of each? In our sudden death cases, we've shown that rupture is seen in 65%, erosion in 30%, and calcified nodule in 5%. Mind you, our mean age is very low as compared to what you all as cardiologists see in the cath lab or patients in the emergency room. Usually those patients are close to 60 years of age. So we see sudden death occurring much earlier. Our mean age is about 49 years. So if you look at, again, further progression, other lesions that we see besides what has been described is intraplaque hemorrhage is another way the lumen can narrow when intraplaque hemorrhage occurs. And I'll get into that why and how it contributes. Heel plaque rupture, you can have silent heel plaque ruptures, and you could have single layer of healing, and that shows the heel. This is the fibrous cap, which is ruptured here, and you see the surface, new intima formation, new growth that has occurred, and that this is related to a previous ruptured site. And this one is there are multiple rupture sites. Now you can have chronic total occlusion, which as shown here can have multiple lumens, and the main lumen is a very small lumen, or there may be no lumen at all. Fibrocalcific plaque are the lesions that are burnt out lesions, what I call, and that they become more calcified with time, or the patient has diabetes mellitus, or in chronic renal failure and is in on hemodialysis for a long time. Nodular calcification, again, I will come back to that. These are lesions that are highly calcified, but the calcium is broken into multiple pieces and that there is still a fibrous cap. And then fibrous plaque, these are lesions from propagated thrombus that can heal and lead again to just healing fibrous tissue deposition along with smooth muscle cells. So looking at early lesions, we wanted to understand early lesions, pathologic intimal thickening without macrophage, with macrophage, early fibroatheroma, late fibroatheroma. Here we've shown macrophage infiltration, T cell, vasovasorum, and apoptosis, that is the macrophages are dying, and that it can also occur from smooth muscle cell death as well. And that you can see that apoptotic bodies are lying free. They're usually not within macrophages as seen here, because these are defective macrophages and cannot take up these apoptotic bodies, which therefore leads to the necrotic core formation. And you see T cells also participating and vasovasorum increasing as the plaque enlarges. And the early lesion, pathologic intimal thickening, has lipid pools, not a necrotic core. These lipid pool lesions can form fibroatheromas by macrophage infiltration, and that the matrix is dissolved by these macrophages, liberating matrix metalloproteinases. And eventually you can get a true necrotic core, which is pultaceous debris. So here is showing what we see in these lesions by measurements, IEL, EEL, and then you can see here the lesions of, this is showing you the percent narrowing. You can see that it is increased. This is lumen area. The percent narrowing increases as the plaque enlarges, and that this is the area of the necrotic core. Macrophage infiltration, apoptotic bodies increase, and engulfed apoptotic bodies decrease within the macrophages because they're defective, they can no longer take up, and therefore that necrotic core enlarges because of death of foamy macrophages. We also need to learn about the Glagoff phenomenon. Glagoff was the scientist who first described that the lumen remains the same besides plaque enlarging. The plaque may be as much of 40% area stenosis may occur, but the lumen remains the same. That is, the vessel remodels and enlarges. So how does after that, only after that, does the lumen compromise occur? And why does that occur? I believe it occurs because of silent ruptures can occur, or they can be silent and these can heal, or they can be intraplaque hemorrhage and the lumen can become much less severely, much greater narrowing can occur, and that leads because of sudden amount of hemorrhage within that necrotic core, enlarging the necrotic core. So these are examples in which the phenomenon of positive remodeling occurs, and there are lesions like plaque erosions. Actually, we see negative remodeling in them, and therefore I think they may be related to spasm, and I'll come back to that. So we described many years ago and published in New England Journal this paper on what contributes to cholesterol. So what we did, we looked at areas where there was hemorrhage, for example, hemorrhagic pericarditis. What does that look like? When you look at it, it is full of cholesterol clefts. Where do they come from? There are very little macrophages present, and you find that there are, on the side of these cholesterol clefts, there is glycophorin staining, which is the red cell membrane stains for glycophorin, suggesting it's the red cell membrane that gives rise to the free cholesterol. And the free cholesterol that accumulates in large amounts in these necrotic core doesn't only come from macrophages foam cell, but really large amount comes from hemorrhage. And that we showed that if you look at glycophorin A staining as plaque enlarges, this staining increases, iron deposition increases, necrotic core formation occurs, and that you can also see macrophage infiltration increasing. Because there's so much lipid deposited, you need macrophages to clear it. So therefore, That's why inflammation occurs in large amount. So suggesting that where do they come from? We believe they come from the vasa vasorum. These leak, and that gives rise to vasa vasorum. And I'll come back to that in a while. So plaque rupture and thrombosis with or without hemorrhage and underlying mild stenosis is a mechanism of rapid plaque progression. As you can see here, there's a plaque rupture right here. This gray is the dye that we injected in this autopsy case to show you that there is thrombus, but the lumen is wide open. This will heal and give rise to healed plaque ruptures or thin cap fibroatheromas first, that rupture, and then give rise to also you can get plaque hemorrhage, and that can also contribute to luminal narrowing. So why healed plaque ruptures are important for luminal narrowing? If you look at, this was work done by Davies, and he showed that previous healed plaque ruptures are important cause of luminal narrowing. If you look at 50% and greater lesions that have narrowed with greater than 50% narrowing, if you look at how frequent is the incidence of this plaque rupture, you can see this fibrous cap with picrocerous red, and if you polarize it, you can see this fibrous cap is made of type 1 collagen, whereas the new neoentima that forms on the surface, that is the organized thrombus, is type 3 and type 4 collagen. And you can see here that 71% healed plaque ruptures were seen in those that are greater than 50% narrowed. That is not severely, but 50% cross-sectional area narrowing. And if you look at those less than, you can find that only 16 of the cases versus 52% of the cases had healed plaque rupture. We did a similar study and looked at the number of prior healed plaque ruptures. We showed that as the number increases, the amount of stenosis increases as well. And this is cross-sectional area stenosis, 50% one, and I think that's how plaques enlarge and lumen narrows from healed plaque rupture silent. So why are macrophages important? One of the things I told you, hemoglobin, heptoglobin, hemoglobin is an important cause of the cholesterol cleft. And we know now that there are not only one type of macrophage, which we used to think as single type of monocyte, which can give rise to only one type of macrophage. But actually now we know there are different types of macrophages. Type 1 macrophage is the foamy, which deals mostly pro-inflammatory cytokines, and lipoprotein saccharides. They also deal with cholesterol. And foamy macrophages form from the type 1. And that is very rich in TNF-alpha, IL-1, IL-6, and IL-12. What I want to talk about is the hemoglobin-heptoglobin complex. This is 100, and they have CD163 positive surface. They secrete cytokines as well, which can also be a cause progression. And how does it cause progression? I will explain to you. So we did a very small study in which we showed that if you look at the necrotic core area where there are predominantly foamy macrophages, and you compare that where there's angiogenesis and hemoglobin that is present or iron is seen, that you can see in here there are different kind of macrophages. So when you look at the control areas, that is where there is necrotic core, you can see here, unfortunately, I can't see the here. You can see here the CD160, CD68 macrophages are greater in the control than the area of angiogenesis, hemoglobin, or iron. If you look at CD163, which is the hemoglobin heptoglobin macrophage, there are greater areas, CD163 present around those areas of angiogenesis. This is a different kind of macrophage. And same way, you can also stain the same cells more or less with CD203. This is the mannose receptor. And if you look at CD36, which is the lipoprotein receptor that takes up and takes up the lipoprotein, making into foamy macrophages, you can see that it takes up, but whereas the CD163 macrophage doesn't take up the lipid at all. So it is as shown here in the lipid sections, you can see there is very little lipid uptake. That is, CD63 are really very little lipid present within these macrophages. And oil red O staining also shows that there is very little lipid present in these macrophages. So why the importance of this? We believe that these macrophages are important, that take up CD163 through HIF1 alpha. They increase the amount of VEGF secreted. The VEGF is responsible for the angiogenesis, V, coherent, and vascular permeability. This increases, and so you get monocyte lymphocytes coming out, as well as hemorrhages occur because these vessels are not very competent. They are leaky because of the permeability, because of VEGF A present, and as well as the receptors, which then help with the leakiness of these vessels expressing. And so the cycle repeats itself. If there's hemorrhage, this is then, again, more macrophages come in, which are CD163 positive, and they then actually continue the cycle, keeps repeating, and more necrotic core with cholesterol formation occurs. Now, looking at features of plaque rupture, you can see 60 to 65% thrombi and sudden death occur from plaque rupture. Here's the thrombus, here's the underlying necrotic core. Same way you can see that the fibrous cap is infiltrated by macrophages, as shown here. It is broken. And you can see that it has also got T cells, but very few smooth muscle cells. And they are HLA positive, that is, they are activated cells. So the ruptured features are thrombus, large necrotic core, fibrous cap covering, thin cap, which is less than 65 micron in the 95 confidence interval, many macrophages, few smooth muscle cell, expansive remodeling of the is preserved. This occurs more. Neovascularization, vasovasorum, plaque hemorrhage, adventitial perivascular inflammation, spotty calcification, inflammation at the medial, intimal medial border is also seen. That's what we reported characteristically. Now, these are lesions we should recognize as vulnerable lesions, or lesions which are called as thin cap, because they resemble plaque rupture, except the fibrous cap is not discontinuous. It is not ruptured. And therefore, the fibrous cap is important. It protects the underlying necrotic core and doesn't allow thrombosis to occur. So if we could recognize these lesions, chances are we can actually prevent the further disease progression. In these people, we could treat them with statins, with PCSK9. We could do all kinds of other things that would prevent patients from having acute myocardial infarction and loss of their muscle. I won't go through this because I think I may run out of time, but in any case, when you look at plaque ruptures, thin cap fibroathromas and plaque ruptures, this is the thin cap fibroathroma with necrotic core. So whereas ruptures are these other ruptures, those are greater than 75% narrowed, and majority of them have very large necrotic core. If you look at those which are severely narrowed but have thin caps and are vulnerable lesions, you can see that their necrotic core is not as large as what we see in those ruptured. So necrotic core is a very important contributor. If you look at 50 to 75 lesion narrowing, you can see here the necrotic core was not that large. Perhaps these should have been silent, but they must have embolized and therefore given rise to an arrhythmia because of local necrosis that have occurred. And that these vulnerable plaques, we probably could treat these in time so that they don't go on rupture. Less than 50% of very few cases, therefore not worth going after. I'm switching to plaque erosion. This is a perfect example to show that this is a 32-year-old female who 2 weeks before sudden death had chest pain, went to the emergency room, and the emergency room didn't find enzyme rise, didn't find anything, sent her home. 2 weeks later, she is dead because her plaque has progressed. It has healed, that thrombus is healing, and you can see the luminal narrowing is severe. And what we show that these lesions are more common in women. Now I can switch this to so that I can see it better. You can see here in women in the 30s, 40s, 50s have much greater plaque erosion as a cause of thrombosis than men. Overall, at 30s, men have a high incidence, but beyond that, it is mostly related to plaque rupture. So women have more heart disease when they have heart disease when they're less than 50 years of age, before menopause. Likely it'll be from plaque erosion. Now, what are the underlying lesions? Pathologic intimal thickening in 16%, early fibroatheroma in 50, and late fibroatheroma with a necrotic core in 34. But all of them have a thick fibrous cap. They do not have any continuity. We think these the medial wall is more or less intact in these, and I think these undergo vasospasm because of stress. So these are things to think about in women. If they don't show severe narrowing, as in this case, it could still be from plaque erosion, and not to think they don't have plaque erosion or don't have thrombus. What about calcification? Plaque ruptures have much higher calcification than plaque erosion, and you can see here 56% of plaque erosions don't show any calcification, 40% show some calcification, and very few have sheet calcium that I'm showing here. That is sheet calcification. This is fragmented. This is no calcium. So overall, if you look at men and women, the red circle, if you look at men, in less than 50 years, plaque rupture is more common than plaque erosion. If you look at women, less than 50 years, plaque erosion is more common than plaque rupture. And if you look at total calcified nodule, this is much less, and I'll come back to that. But if you look at women beyond 50 years of age, plaque rupture becomes the dominant lesion, plaque erosion almost disappears. So as if, and just like I'll come back to calcification, the same thing happens with calcification. So coronary calcification. There are three categories of coronary calcification. They can be inflammatory, metabolic, and inflammatory being atherosclerotic. Metabolic is diabetes and CKD. And then genetic causes. These are genetic disorders. That is the calcification of infancy is a common, and pseudoxanthoma elasticum, and there are other Marfan-like syndrome. You can also get calcification. And I'm not going to address that, but I'll show you that these are the three types. You can see inflammation leading to calcification. There is, in the peripheral artery disease, medial calcification is dominant, which is really not seen in coronary arteries. And this can lead to symptomatology just from medial calcification. And you can get intimal proliferation, but no atherosclerotic disease may be seen. And then this is arterial calcification infancy. You can see it in this child, 6 months old. You can see highly calcified arteries, as shown here, you can see. So these are the various causes of calcification. I'm going to address calcification in terms of atherosclerosis. We start with microcalcifications, which are seen in pathologic intimal thickening in areas of lipid pool. You can see these little black dots. These are calcium and stained by Van Casa stain. You can see when macrophage infiltrate, these can undergo apoptosis and then calcification. This is called as punctate 5 to 15 micron. Fragmented calcium, when it is usually seen at the border area between the media and the plaque itself. And you can see that this is calcified and it is usually greater than 1 millimeter inside. We call collagen sheets when it is collagen which is calcifying, and you can see this sheet, and we stain with picroceros red, we can see that type 1 collagen is present. Whereas when the necrotic core calcifies, there is no picroceros red staining in the area of the necrotic core because there's no matrix. Nodular calcification, you can see the nodules, and then calcified nodule surface thrombus is seen, and you can even see bone formation. As shown here, you can see bone formation in 5%. It's much more common in peripheral arteries. This is to show the mild and severe calcification. This is diffuse. You can see by radiology X-ray, you can see fragmented calcium and showing you here calcium in a case of plaque rupture. This is the least calcium. When you have diffuse, it is more likely calcific plaque and not a lesion that is going to rupture. These are just to show erosion lesions. Very little speckled calcium can be seen. You can see here speckled, larger speckles you can see, which are about 1 micron, 1 millimeter, which can be seen by radiograph. And then you can see fragments of calcium. You can see diffuse calcium. And this usually fragments is what is seen in plaque rupture. And I'll show that thin cap fibroadenoma, again, showing fragmented calcium. Now, if you look at X-rays by radiograph, and this is by histology, what type of calcification do we see in erosion? We see usually none or speckled, or we see micro and fragmented calcium. If you look at thin cap fibroadenoma, we see diffuse, fragmented, or speckled. Very few has no calcium. Same way in histology, sheet, fragmented, micro. And if you look at ruptured, very similar. Very few have no calcium. Speckled is the more common, 50%. Fragmented, another 30% or so, and diffuse calcium, but very few have no calcium. Heel plaque rupture, on the other hand, show more diffuse calciums and more fragmented calcium. Same way in the microcalcification. If you look at histology, sheet and fragmented, fibrocalcific is diffuse. We see sheet calcium or nodular calcium in these cases. We can show that as plaque becomes more and more advanced, that is 0 to 10, anywhere to 100%, by 80%, they are almost all calcified. If there is calcium, if there is plaque that much, you will see some calcium at all. So this shows you the mean calcification area. And you can see that there is a good correlation between square root of calcium area and square root of plaque area, but not with the square root of calcium area versus square root of lumen. There is no correlation between the lumen. So what about males and females? As age advances, you can see here blue in males, females. You can see that females only catch up in the 70s, getting more similar amount of calcium as in the males. But before that, calcium is much less. We think this is from the protection with estrogen, maybe a protective mechanism. If you look at black and white have more calcium than the blacks, and this is showing again by histology, we're showing these. We've also looked at X-rays to some mild calcium, moderate calcium, and severe calcification. This shows you none and what type of plaque it is, whether you see ruptured or you see stable plaque or you see erosion or you see ruptures here or no significant calcification. Mild, you can see again what type of lesion. As mild and moderate, you see more with plaque rupture. Severe calcification, you see more unstable plaques. So what are the mechanisms? Cell death, circulating nucleated, you can be from cell death. I think majority, I believe in this, that majority of the calcification that occurs from cell death. Hyperphosphatemia and hypocalcemia also play a very important role. As you know, in renal failure, these are the things which are elevated. Also, people believe in matrix vesicles. They are released from apoptotic cells, or they can be released by living cells, smooth muscle cells, as well as macrophages. And these circulating matrix vesicles can become calcified. And that is another mechanism people have said. Then there is loss of inhibition. There are protected cytokines which can protect you from calcification, and they may be lost, and that can lead to calcification, or even bone formation can occur through osteoblast conversion, which I don't believe, because we very rarely see bone formation, which is seen in 5% of the cases. So majority, I believe, occur from cell death. So calcified nodule, These are lesions that have nodules of calcification, but this is by micro CT just to show you the nodule. This is a sheet calcium, necrotic core calcium, and this is sheet calcium on the outside. So I'm going to skip a little and be able to show you calcified nodule, sheet calcium. You can see calcified sheet, calcified necrotic core, and nodular calcified nodule and nodular calcification where luminal thrombus occurs. These have collagen as a background. This is which is calcified necrotic core. This is calcified sheet. This has no calcium, no matrix at all, and has calcification. This is nodules of calcium that have formed, and you can see likely they occur from the same case of nodular calcium, which doesn't have the strength that this will have. And I'll get back to that in a moment. So what we did, we looked at lesions that had, this is a 79-year-old woman with hypertension, diabetes, congestive heart failure, died suddenly, calcified nodule. This is the area, a D, that is showing you the calcified nodule with surface thrombus. We did serial sections proximal and distal to it, and you can see that the lesions proximal to it are very rich in sheet calcium. And you can see this sheet calcium here, whereas distal lesions similarly have more sheet calcium, as shown here in these lesions. Now, what we did was we studied these at culprit sites of calcified nodule. 28% had what is known as necrotic core calcium, whereas proximal and distally, there were more calcified calcium. That is, collagen calcium was much more prevalent. This type of calcium was much more prevalent, suggesting that there may be a mechanism that because of tortuosity of the vessel movement, that those areas protrude out into the lumen and lead to nodules forming into the lumen, and that the surface may have even a thrombus on it. And this is to show you by micro CT the nodules of calcium. As you can see separately, this is cross-section. This is the whole 3D rendering of that site of calcified nodule, which can be towards the outside as well as towards the lumen. Again, showing you the same surface calcium, the nodules of calcium, and on each side, you will find proximal and distal, there is sheet calcium present, which is collagen calcium rich, which is much more dense than the nodular calcium. So we believe at ruptured site, there is constant motion, and that these are harder and therefore don't rupture. The inside where there's the necrotic core calcium, this protrudes out and leads to the nodular calcification. So I think the flexibility and tortuosity and the more stress leads to the formation of nodular calcification and surface thrombus. I think I'm going to skip this because subclinical atherosclerosis is very important. I think we should start recognizing in patients, if we're going to prevent sudden death, this is the idea. We need to recognize subclinical atherosclerosis in the presence of atheromatous disease. In one or more arterial territories before there are any signs and symptoms or events attributable to the clinical manifestation of atherosclerotic disease in that territory. If we can recognize this, the early indicator of atherosclerosis burden is the importance, because timely intervention could prevent further cardiovascular morbidity, mortality. Differences between clinical atherosclerosis, subclinical atherosclerosis is whether the presence of atherosclerosis results in clinical symptoms of ischemia, such as stroke, myocardial infarction, and chronic limb-threatening ischemia. I think subclinical atherosclerosis is a lesion in which it can be classified into three categories. Non-ruptured plaque without severe stenosis, that is less than 50% diameter stenosis, that can encompass multiple morphologic types, that can be pathologic intimal thickening, could be fibroatheroma, and also calcium, as you know, has been shown to be an indicator of plaque burden. Thrombus formation following plaque rupture, plaque erosion, or calcified nodule that results in no ischemic events, but heals and results in luminal narrowing that is less than 50%. Or lesion 50 to 99% narrowing, chronic total occlusion due to progressive atherosclerosis without causing clinical symptoms. As we know, if you take a patient who has some vague symptoms to the cath lab and is getting to at least 20% will have already a chronic total occlusion. So these atherosclerotic lesions are PIT, early fibroatheroma, late plaque hemorrhage, thin cap fibroatheroma, could be heel plaque rupture, and fibrocalcific plaques. Now, silent ruptures and plaque ruptures and chronic total occlusion, all types of plaque can cause severe stenosis. Three main causes of thrombosis, plaque rupture and erosion can also occur silently, as I already showed you. So going on to vascular beds, I just want to skip and show you here that if you were to look at, I'm going to skip this and just go on and show you the summary. Lesions of subclinical atherosclerosis are lesions with less than 50% diameter, 50 to 100% diameter, can be clinically silent. These include pathologic intimal thickening, fibroatheroma, thin cap fibroatheroma, ruptures that don't cause severe narrowing or cause any symptoms, or erosion or calcified nodule, and diameter stenosis less than 50% in heel plaque ruptures and silent total occlusions. If you look at vascular beds, where does it first show the disease process itself? Lower extremities is high, followed by carotid disease, followed by aorta, and least is calcification, or that is coronary artery disease, frequency of that. If you look at location of atherosclerosis, we find by the highest in case of aorta, ascending aorta to bifurcation is full of atherosclerosis, and that can be an indication that there is silent atherosclerosis. The mechanisms we already talked about. In the aorta, there'll be penetrating ulcers or thromboembolism or cholesterol crystal emboli can occur. Lower extremity stenosis, thromboembolism, diffuse medial calcification, and carotid thromboembolic disease, stroke, TIA, severe thrombosis. These are the symptoms. So how can we assess these? I think OCT and IVUS is out because these are invasive, and nobody who's asymptomatic is going to take them to the lab and do these things. So multi-slice CT or MRI are the best. MRI is not as good as recognizing as multi-slice CT, and now the amount of exposure to radiation is much less, can be much less, and the resolution is good enough that we can recognize high-risk plaques as well as calcium. And that calcium score can give us an indication that this patient is more likely to get sudden cardiac death. I believe people should start being recognized as in trouble if they have high calcium scores as compared to the counterparts. And that if that is so, then we should be treating these patients aggressively by medical therapy. So I'd like to end here, and this is my summary slide, which I've already talked about, and I won't read it to you. So if I can be of answer any questions, I'll be happy to do that.
Yes, Dr. Hirmani, thank you so much for this fascinating journey into the universe of atherosclerosis. So what would be your advice in terms of stopping the progress and trying to reverse it?
I believe I think you must try statins as well as PCSK9, depending on what the cholesterol is and how you can reduce it. It has to be less than 200. I believe in every person, it should be less than 200. Any adult, I will say. So in anybody who's greater than 18 years of age should have cholesterol checked, and they should be on statin therapy first as a trial. And then if need be, and the lesions get to be high-risk plaques you recognize, then perhaps treatment with interventions may be necessary.
So would you recommend the screening to start in early adulthood?
Yes. I believe the only way we will reduce these kinds of deaths, my registry now has over 1,500 cases of sudden death that I've collected from Maryland Medical Examiner's Office. And I tell you, I am a believer that we can save these lives if we were to screen them at the age at least of 30 to 35 years of age. What do you think of my idea?
I think it's fascinating, but if you think in terms of populational health at 7 billion people, would you screen worldwide people for?
At least I think in the United States, I wanted screened. At least we, as a country, can afford it and could be able to pay for it and should be able to pay for it. Now, yes, if anybody who can afford it and can get, ideally, I would say everybody, every human being should have this test done. First, at least risk factor screening. If the screening looks good and there is no need for it, those subgroup of patients who have a high cholesterol, maybe that's what we need to do in them.
Did you see in autopsies, I mean, causes of death that were not cardiac related, so violent death or so? Have you ever seen regression of atherosclerosis?
I call regression of atherosclerosis as having more calcium. Diffuse calcification, fibrocalcific plaque, to me, are silent plaques. They are not going to give you trouble unless the lumen is severely narrowed. Otherwise, they are not going to lead to thrombosis. Surface doesn't do, unless they get calcified nodule, which is rare cause, as only 5% of our cases had calcified nodule. But these are young people. You are seeing much older people. So the incidence likely is higher in you.
Not absolutely. I mean, unfortunately, we had in our practice patients who came with heart attack in their 30s. And that was extremely, humiliating to see that. Mostly we do intravascular imaging during the cases. And then we see this amount of plaque that is extremely, extremely impressive. And again, I think it's a combination of lifestyle, mostly smoking.
Yes, smoking, no doubt. I mean, smoking, diabetes, our thing, obesity must be reduced because that also is leading onto high cholesterol and other factors in diabetes, which is inflammation of the arterial wall. So smoking, definitely, no smoking. I agree with you.
Dr. Ramani, what are your thoughts on this new CT that's using AI to enhance analysis, and do you see a role for that?
I think there's a role for it because, we have to be consistent in our reading. There is otherwise physician to physician variability and how they read and how they tell. I think machine learning is going to be a big progress, I think, in doing CTs and making it easier to know where you stand in terms of calcium. And high-risk plaque, if we can recognize high-risk plaque, that's another thing. We can change that venue. For example, if there is 75% narrowing cross-section area and there's a vulnerable plaque, I am in favor of treating it. And I think so are you.
Dr. Varmani, there are a couple of questions in the chat I'm going to pose. Dr. Hamidani is asking, I know you have worked with Dr. Williams in developing elicit CTA plaque analysis. There has been some questions in regards to comparing coronary vascular bed plaque with carotid plaque. Wonder what are your thoughts about it?
Carotid plaque is a very necrotic core rich. It has a lot more foam cells than does coronary even. And these are symptomatic individuals. If you look at asymptomatic, which are severely narrowed, they are rich in calcium. So there is some differences. Stroke patients and those with TIAs have much more plaque rupture, and they have large necrotic cores majority of the time. And these patients also have very rich foam cell lesions in them.
Thank you, Dr. Varmani. There is another question in the chat from Dr. Abhiram Reddy. Increasing screening tests to the extent so that all true positives and false negatives patients are covered at the primary level of intervention so that more dangerous effects of atherosclerosis can be avoided for patients in the future.
Absolutely. I'm a believer in that. I think screening Framingham Risk Index must be done first before we start doing CTs. And then if there is indication that they're somewhat on the higher end, those patients at least can undergo, especially if their cholesterol is greater than 200. I think those patients should undergo CT.
We mentioned a little before your talk about colchicine getting FDA approved. Do you see it, transforming into clinical utility, and where do you see that going as far as clinical practice goes?
I don't think that people will start taking colchicine or should start taking colchicine as a preventative. I think we don't see that much inflammation in the early plaques. We see more inflammation in the late plaques. High-risk plaques have more inflammation, and we're actually doing some work showing that the T cell and macrophages are much higher, and B cells tend to be in the adventitia, which is sort of a protective mechanism. But I think early on, colchicine is not in those who have already manifest their disease. I think as a secondary phenomenon, along with statins, they should get both.
What are your thoughts about the micro nanoplastic described in
Yes.
plaques?
I don't believe it. I am not impressed, and I am going to do a similar study if you can provide me with carotid plaque so that I can get coronary, and I'm going to do coronary anyway. But I do not believe that these, and I hope to be able to show one way or the other whether they're right or wrong. How often do we see them? I think they're over assessing. I don't know how they were preserved. I don't know, remember, formalin comes in plastic containers, and we know that there are nanoparticles or microparticles of plastic and nanoparticles actually in that water that we drink. I totally agree with that. And I'm sure we're breathing some of it too. But does it go and reside in the plaque, and that causes more symptoms and more deaths from that? I don't believe it. I just don't think. I think lipid, which is circulating, is a much better. If you find 1 or 2 particles in a plaque, I don't think it's going to cause you problems. So I don't believe that study. I'm skeptical, I would say. I don't know what your thought is.
Well, it's very intriguing because in Europe there is a huge, search for plastic in tap water, in everything that's in the food, and there is like a pendulum swinging away as much as possible from plastic. So this paper coming obviously from Italy that was published last week in New England is a little bit concerning if it's real. I mean, I agree. I mean, you need to replicate the data and you have to show consistency here.
You have to show consistency and show me that it is, why is it not present in half the other people? Give me that. Why is it only in these people?
Well,
that only half the
background.
population. Is it that, they were not drinking plastic or not drinking bottled water? Or is it that they were not breathing? They come from the same population. I'm sure our macrophages within the lung show us presence of plastic. I wouldn't be surprised at all. But in circulation, I'm a little skeptical.
How long does it take to achieve complete stent endothelialization with the newest generations of stents, and to that extent to be sure, or at least very comfortable to avoid late stent thrombosis?
There are so many factors that influence it. It depends on the inflammation. It depends on the drugs that you're using, how much drug there is in, how far away are you from the site of your stent strut, where are you looking? So there are many, many factors. I would say, we looked at endothelization. We can say for sure that it'll take 6 to 8 months before the surface gets in humans, not in animals. Animals is much faster. Much faster, because there is no underlying disease in our animals. In humans, we've got underlying disease, and that also prevents, if there's calcium there, that is not going to have much of endothelium on the surface to begin with. So you're not going to get endothelization of that. If you have a necrotic core, those struts are going to be embedded in the necrotic core, and that the drug is going to sit in the necrotic core for a much longer time because there's no way to take that necrotic core away. I don't think when you give people lipids, that necrotic core shrinks. They say it shrinks, but I think you're looking at collagen deposition and that cross-links and gives you an idea that it is a smaller necrotic core. I think it calcifies with time.
Does that mean you're not a big advocate of shorter durations of DAPT or monotherapy or?
If I was 30 years old, I needed a stent, or 35, I hope not, but nobody should need it at that age, say 45 years. And I needed a stent. I would definitely take a stent, but I would make sure it was the kind that I think has not too much drug, definitely not paclitaxel coated stent. I would have sirolimus. I would make sure that it is the type, the polymer is such that it doesn't allow thrombus to form over it. So these are things I would make sure. And I would take anticoagulants for a long time. If I'm young. Now, at this age, now that I'm old with gray hair, I would not take anticoagulant for too long because there are so many disadvantages of anticoagulants. So bleeding is a big problem. I more likely will have intracranial bleed and die from that rather than from that stent. I would take aspirin. I would take Plavix. I think Plavix, but not systemic anticoagulants.
And Dr. Vermani, we have 2 more questions if you have time.
Sure.
Yes, this is from Dr. Kameshwari Maganti. Dr. V, thank you for the wonderful grand rounds and adding so much to cardiology literature. You have shown that it takes more than 2 years prior to complete healing following DES placement. What are your thoughts on stopping DAPT in 3 to 6 months these days? Thank you.
I'm not, as I said just now, I don't believe 3 to 6 months is enough. 3 months certainly is not in most patients, but you have to weigh the bleeding effects. And so it's not a simple question of, I think DAPT is mostly tolerated fairly well, at least one drug. I would definitely take for 3 months both drugs, and beyond that, I would be on one drug at least.
And our last question in the chat is for today. Any thoughts on GLP-1 agonists and CAD prevention at the vessel level?
CAD, what do you mean by CAD?
Coronary artery disease.
Prevention, I think, as we discussed this, I think statins and must reduce the total cholesterol levels is a must. And then there may be a role for anti-inflammatory, but at least as yet, I haven't seen enough of that. Maybe colchicine could be added since it is doesn't have that many side effects.
Thank you so much. Dr. V and Dr. Zakir, any questions?
Yeah, I mean, we want to thank you so much for sharing with us your experience in the field. Obviously, you write the book and we are the students. Over the last decades, we learn a lot from you, and the way that you looked into these things is fantastic and helps us a lot in our everyday practice. And I want to assure you that whatever you do at basic science level, we benefit tremendously at bedside and in our daily interaction with the patient. So I want to thank you again for agreeing to be speaker for us, general speaker, as well as for all the fantastic work that you do in this field.
No, thank you for inviting me. And indeed, it is a pleasure to give this grand rounds, and just very nice to know all of you and increase my world of knowledge from all of you as well. Thank you.
Thank you.
Thank you, everyone. Have a good evening.
Thank you.